السلام عليكم. I am Dr. Umayma Abdelmun'im. I will start with you our lectures in pediatric tropical diseases. There will be 3 lectures. Our first lecture we will talk about malaria and typhoid fever. We will start firstly talking about malaria. The objectives of this lecture are: we will talk about etiology, transmission, epidemiology, pathogenesis, clinical manifestations, diagnosis, treatment, complications, and prevention. Etiology. Malaria is caused by Plasmodium species, which are intracellular protozoa. There are 4 main species causes malaria in human: Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, and Plasmodium malariae. Transmission mainly by female Anopheles mosquito. Blood transfusion is another mode of transmission, transplacental from mother to her fetus. This is a photo of a female Anopheles mosquito. Epidemiology. Malaria is a major worldwide problem, mainly found in Africa, Asia, and South America. In Sudan, malaria is an endemic disease اللي هي واحدة من الأمراض المتوطنة. Plasmodium falciparum constitutes more than 90% of cases, Vivax about 6 to 8%. Pathogenesis. There are 2 life cycles of this Plasmodium. One in human, which is considered as the intermediate host. What do we mean by intermediate? Intermediate means the host where asexual phases of life cycle occur. And the mosquito is the definitive host where the sexual phases of life cycle occur. In humans, there are also 2 phases. Exoerythrocytic phase occur immediately after mosquito bite, and within minutes the sporozoites will go directly to hepatocytes or liver cells, transform to schizons. What the word schizons mean? Any cell containing more than 1 parasite called schizons. After 1 to 2 weeks, these hepatocytes will rupture, releasing merozoites. There is an important note is that in Plasmodium vivax and Plasmodium ovale, some hepatic schizons remain dormant اللي هي خاملة, called hypnozoites. This will lead to relapse of malaria. In these 2 special species هما Plasmodium vivax and Plasmodium ovale. Erythrocytic phase starts when these merozoites penetrates the RBCs or the erythrocytes, transform to trophozoite, and multiply, forming a schizont. Then it will rupture, releasing merozoites, attacking a new RBCs. عشان كده هي repeated cycles. This is why destructions of RBCs occur in malaria. Some of these merozoites develop into male and female mosquito taking its blood meal. It will ingest these gametocytes. In the intestine, they will fuse, forming a zygote, an ookinete, an oocyst, and then transform to sporozoites, which enter the salivary gland of the mosquito, ready for a new cycle. There are 4 pathologic processes have been identified in malaria. Fever occur with erythrocytes rupture. Anemia is due to hemolysis of the RBCs and to sequestration in the spleen. Cytoadherence of infected RBCs to vascular endothelium will lead to obstruction of blood flow to organs of the body, like the brain, leading to cerebral malaria, or to the kidneys, leading to renal failure. Hypoglycemia and lactic acidosis are due to anaerobic metabolism. This is a photo of life cycle. As you can see, step 1, sporozoites enter bloodstream, goes directly to liver cells. This is a schizont, as you can see, with multiple parasites inside. They will rupture releasing merozoites. This is entering the RBCs, okay, attacking a new RBCs, or transform to gametocytes, which are taken by the mosquito and change to ookinete, oocyst, and then sporozoites. Incubation period is between 9 to 14 days. As we know, the incubation period is the time between the entry of the parasite to the time of showing symptoms and signs. Main symptoms and signs are fever, rigors, sweating, headache, myalgia, abdominal pain, vomiting, and diarrhea. Fever is the main symptom, so there is no malaria without fever. In this picture, you can see malaria can affect the CNS, leading to headache and maybe convulsion in severe cases, fever, muscular, patient can have fatigue and pain, back pain, chills and sweating. He might develop dry cough, splenic enlargement in the stomach. He might have nausea and vomiting. Complications of malaria اللي هي دي signs of severe malaria اللي هي severe anemia, cerebral malaria. In severe anemia, this, as we said, is due to excessive hemolysis of RBCs or due to sequestration of RBCs in the spleen. Cerebral malaria, the patient might have headache, convulsion, or impaired level of consciousness, and he might come in complete coma. Hyperparasitemia, this is by microscopic examination of blood. This is explained as crosses. In one cross shows 1 to 10 parasites per 100 field. 2 crosses, 10 to 100 parasites per 100 field. 3 crosses, 1 to 10 parasites per field. 4 crosses, 10 to 100 parasites per field. So 3 crosses of malaria or 4 crosses are considered as hyperparasitemia. Black water fever is the appearance of hemoglobin in urine. Hemoglobin is the features of severe malaria, black water fever. Patient may present with pulmonary edema. The main symptom will be respiratory distress. Algid malaria, patient will present with symptoms and signs of sepsis and shock. He will present with poor perfusion and severe hypotension. Laboratory diagnosis of malaria, the main way of diagnosis is blood film for malaria, isolating the ring stage or the trophozoite. Blood film, there are 2 films done, thick blood film for diagnosis and thin blood film for identification of species. The stain we use is the Ginza stain. There is another way which is called rapid diagnostic test or ICT. In this case, the test will detect the antigen of Plasmodium. Another way of diagnosis is the PCR, which detects the DNA of the parasite. This is a photo showing this is the ring stage. As you can see, it's a ring shaped. Okay, this is a schizon, the cell containing many parasites inside. This is female gametocyte, which is called macro gametocytes, and this is the male, which is called micro gametocytes. Treatment for simple malaria is the combination therapy between artemether plus lumefantrine, which is called Quartam. For severe malaria, usually we use quinine and artesunate injection. Prevention. The aim of prevention of malaria is to prevent the mosquito from reaching our skin and not to take her blood meal. Okay, this can be done by mosquito netting, window screen, wearing protective clothing, or we try to get rid of the mosquito by using insect repellents اللي هم طارد الباعوض, insecticides, draining stagnant water to reduce breeding sites. Another mode of prevention is use of chemoprophylaxis. This is used for people coming from non-endemic areas to endemic areas. Usually it is used 2 weeks before arrival and 6 weeks after departure. The vaccine for malaria is under trial. Our next talk will be about typhoid fever. The objectives are, we'll talk about etiology, transmission, epidemiology, pathogenesis, clinical manifestations, diagnosis, treatment, complications, and prevention. Typhoid fever is caused by Salmonella typhi. In more than 98% of cases, Salmonella is a gram-negative bacilli. Rarely it is caused by Salmonella paratyphi. Transmission of typhoid is through the GIT by ingestion of contaminated food or water by fecal material. Epidemiology. It is endemic in some developing countries, especially countries with poor hygiene. Waterborne outbreaks can occur in areas with poor sanitation. Pathogenesis. After invasion of the terminal ileum mucosa, Salmonella typhi enters the mesenteric lymphoid system and then it passes through the bloodstream. This is called primary bacteremia. In this bacteremia, اللي هي primary bacteremia, blood cultures will be negative. Then from blood it colonizes the organs of the reticuloendothelial systems, which are the liver, spleen, and bone marrow. It replicates within macrophages and it will be shed back into the bloodstream, leading to secondary bacteremia. This is when blood cultures will be positive. Incubation period usually between 7 to 14 days, but it depends on the number of the invading bacteria. When the number of invading bacteria is high, the incubation period will be short. Stepladder fever or rising temperature, headache, anorexia, vomiting, diarrhea, abdominal pain, hepatosplenomegaly. Complications. Hepatitis and cholecystitis when occurs indicate poor outcome. Intestinal hemorrhage and perforation, toxic myocarditis and toxic psychosis. Lab diagnosis. We will do complete blood count or CBC. Usually we'll find leukopenia اللي هي low WBCs. Blood culture, urine and stool culture done late. Serology اللي هو الفيدال test which detects antibody. It may indicate a previous infection, so it is not diagnostic for typhoid fever unless we find a rising titer اللي هي we do more than one test. نلقاه rising. PCR اللي هي detects DNA of the bacteria. Treatment. Quinolones and third generation cephalosporins have a high cure rate. Prevention. Chlorination of water to get rid of the bacteria. Detection of chronic carriers in food handlers. Vaccination by oral live attenuated vaccine which gives protection for 5 years. Capsular polysaccharide vaccine which needs a booster dose every 2 years. Thank you.